Everyone, welcome to Dr. Sravani's Medconcepts. Today's session will be on usual ductal hyperplasia, which is usually confused with atypical ductal hyperplasia. I tried to explain in a simple way with basic concepts, so join with me for knowing more about usual ductal hyperplasia. This is the WHO classification 5th edition. In epithelial tumors of the breast, we have separate entity known as benign epithelial proliferation and precursors. Under this category, we'll have three lesions, that is usual ductal hyperplasia, columnar cell lesions including flat epithelial atypia and atypical ductal hyperplasia. Our today's discussion will be on usual ductal hyperplasia, which has 1.5 to 2 times increased risk of cancer. Usual ductal hyperplasia is an architecturally, cytologically and molecularly heterogeneous benign epithelial proliferation primarily involving terminal duct lobular units. Coming to the microscopy, ducts and lobules are filled and expanded by a mixed population of epithelial and myoepithelial cells. As we can see here, myoepithelial cells, and these cells are arranged in haphazard pattern as shown here. So we'll see disorganized heterogeneous cell proliferation in case of usual ductal hyperplasia, which is different to the atypical ductal hyperplasia, in which we'll see homogeneous cell proliferation. Cells in usual ductal hyperplasia follow a peculiar maturation pattern. We can divide the cells into peripheral zone and the central zone. In the peripheral zone, the cells are larger, paler, columnar and more organized. When we come towards the center, in the center, the cells are smaller, darker, crowded and irregular. Coming to the nuclear features of usual ductal hyperplasia, in this we'll see polymorphous nuclei, that is nuclei vary in size, shape and orientation, and there will be overlapping and crowding of nuclei. As we can see here in the peripheral, the nuclei we can see the varying sizes, shapes and orientation, and in the center they are jumbled. So nuclei become hyperchromatic and nearly pycnotic in the center. Loss of polarization and variation in nuclear orientation clearly indicates that usual ductal hyperplasia is benign in nature. Coming to the polarity, you can see this is the normal ductal epithelium and atypical ductal hyperplasia and DCIS. In this, how the cells are arranged, they are arranged in orderly fashion, and the nuclei are aligned perpendicular to the basement membrane like a palisade. Polarity is maintained, that is apical versus basal relationship is maintained, and because of which there is formation of structural lumen. So here you can see I am showing with the green colored lines, the epithelial cells are arranged perpendicular to the basement membrane. So they are well oriented. So all the epithelial cells are arranged perpendicular to the basement membrane, forming a structural lumen. Same in atypical ductal hyperplasia also. The cells are oriented perpendicular to the basement membrane, causing a well maintained polarity, that is apical versus basal relationship is maintained. But when you come to usual ductal hyperplasia, the cells are haphazardly or irregularly arranged, because of which this alignment is lost. So they are haphazardly oriented and arranged in multiple directions like this, irregularly going in different directions, and because of which there is loss of polarity, producing irregular secondary lumen. So polarity is maintained in normal ductal epithelium, ADH and DCIS, whereas polarity is lost in usual ductal hyperplasia. So you should remember, usual ductal hyperplasia shows loss of polarity. Coming to the architecture, in the architecture we'll see three patterns: streaming pattern, bridging pattern and fenestrations. Streaming is the cells are aligned in parallel waves, that is there will be streaming of nuclei, and bridging occurs across the lumen in the form of irregular chords, and fenestrations are the slit-like secondary spaces. Streaming and swirling of cells. What is it exactly? The cells, especially in the center, are crowded and often aligned parallelly with no rigid geometric arrangement. So here you are able to see how the streaming of nuclei will be there in UDH. They are parallelly oriented. This is another diagram showing streaming of nuclei in UDH, which resembles a school of fish. So in the center, as we can see here, there is streaming pattern of the nuclei parallelly arranged with one another. So streaming is characteristic of UDH and not seen in ADH or DCIS, where nuclei are perpendicular and orderly arranged. Next category or characteristic feature is bridging. So there are cellular connections which span across the ductal lumen, linking one side of the ductal wall to the other. So as we can see here, there is bridge formation connecting one side of the duct to the other side of the duct. So these are the bridges. This is another diagram showing bridges. So because of bridges, there is formation of lumina. So these bridges are composed of proliferating epithelial cells and may partially divide the lumen into smaller slit-like secondary spaces. So as I already told you, because of bridges, the lumen is divided into multiple secondary lumina. So which are irregular, slit-like and crescent shaped. As we can see here, there are multiple ducts here. Okay, there is epithelial proliferation in all these ducts. This is one duct and this is another duct. Okay, so there are multiple ducts which shows epithelial proliferation, and when we observe here, this fenestrations are in varying sizes and shapes. So secondary lumina are in varying sizes and shapes in case of UDH, but in ADH they will be uniform. That is the classical feature which differentiates UDH from ADH. So the secondary lumina are varying sizes and shapes. So here also you are able to appreciate it. In UDH, the secondary lumina are more oriented towards the periphery, as we can see here. Myoepithelial cells, as in any benign condition, there are myoepithelial cells present intact around the duct and sometimes within the bridging structures, which can be demonstrated by P63 SMA IHC. So here you are able to see the myoepithelial cell rimming at the periphery of the duct. Coming to the patterns of usual ductal hyperplasia, there will be three patterns: solid, fenestrated and micropapillary. In solid, we will have intraluminal proliferation of epithelial and myoepithelial cells with bland nuclei that vary in size, shape and orientation, filling the entire lumen. This is the fenestrated variant. So we'll see the bridging, because of which it is divided into multiple secondary lumina of varying sizes and shapes. So fenestrations, there will be varying sizes and shapes, and there is haphazard arrangement of cells with no regular orientation around the fenestrations. Coming to the micropapillary variant, this micropapillary variant, the cells form slender finger-like projections into the ductal lumen that is known as micropapillae. These micropapillae lack true fibrovascular cores, distinguishing them from papillary neoplasms. And this micropapillae in UDH, they will have broad base, pointed tip, whereas in ADH they will have narrow base and bulbous or broad tip. So this is UDH, which has broad base and pointed tip. In ADH we will have narrow base and broad tip. So this is a diagram showing all the three variants: solid, fenestrated and micropapillary. Coming to the IHC patterns of usual ductal hyperplasia, in the normal breast you will have two layered lining epithelial cells, inner luminal cells and outer basal myoepithelial cells. Immunohistochemically, these two cells differ from one another. Inner luminal cells will express ER most commonly and CK8 and 18. Outer basal or myoepithelial cells, they will express CK5 and 6. So when we stain with CK5, 6, wherever the myoepithelial cells or basal cells are there, they will stain. In usual ductal hyperplasia, what is happening? It is a polyclonal proliferation consisting of both epithelial as well as myoepithelial cell proliferation. Now we are using CK5-6 marker, so which is going to stain the basal or myoepithelial cells. But in usual ductal hyperplasia, along with the myoepithelial cells, luminal epithelial cells are also there, which does not show positivity with CK5-6. So you will see mosaic pattern, okay, consisting of CK5-6 positive basal cells, which are shown as brown here, and CK5-6 negative luminal cells, which are shown as purple here. So in UDH you will see mosaic pattern. And in atypical ductal hyperplasia, you will see monoclonal cell population, which consists only of luminal type of epithelial cells. So this luminal type of epithelial cells, what it will express? It will express ER. But here the myoepithelial cells are absent. So there is no expression of CK5-6. So it shows negative expression in case of ADH. ADH is atypical ductal hyperplasia. Coming to the IHC pattern of ER positivity. So when you stain the case with ER, that is estrogen receptor, what happens in usual ductal hyperplasia? As we have discussed in the earlier slide, it is a polyclonal proliferation consisting of both epithelial as well as myoepithelial cells. So ER positivity is seen in the luminal cells. Here in usual ductal hyperplasia, both are there. So wherever the luminal cells are there, it shows positive, and where the basal cells are there, it shows negative. It is similar to the CK56 positivity. When we stained with the CK56, what happened there? The basal cells got stained, whereas the luminal cells remain unstained. Here with ER, what is happening? The luminal cells are getting stained, whereas the basal cells are remaining unstained. So it is showing heterogeneous pattern. So brown is ER positive luminal cells, purple is ER negative basal cells. But in ADH, what is happening? It is monoclonal proliferation consisting only of luminal type of epithelial cells, and myoepithelial cells are absent. So here what you are seeing, all cells are luminal type, hence there is diffuse uniform positivity for estrogen receptor. Coming to CK56, this is a IHC pattern. CK56 is showing mosaic pattern. Estrogen receptor is showing heterogeneous positivity. So where did you see the CK56 mosaic pattern? In UDH. Estrogen receptor heterogeneity is seen in the same UDH. And in other IHC marker, that is calponin, which is used to demonstrate myoepithelial cells around the duct in circumferential manner, confirms the benign nature of the lesion. As you can see here, only the periphery of the duct, it is showing myoepithelial cells which are stained with calponin. And preserved membranous staining of E-cadherin, which indicates ductal origin. So in UDH, when you stain with E-cadherin, what happens? It shows membranous staining preservation, which we can rule out lobular neoplasia, and it indicates ductal origin. Coming to the summary. So usual ductal hyperplasia consists of heterogeneous epithelial cell proliferation, which includes luminal and myoepithelial cell proliferation. And the cells in the periphery are larger, paler, columnar and organized, whereas in the center they are smaller, darker, crowded and irregular. Nuclei become hypochromatic and nearly pycnotic when it comes to the center. And coming to the architecture, you will see streaming, bridging and fenestrations. Streaming is streaming of nuclei. In this, the cells are aligned in parallel waves, bridging across the lumen in the form of irregular chords, and fenestrations, which are nothing but the slit-like secondary spaces. So these are the irregular bridges which are slender, and fenestrations which are of varying sizes, irregular in shape and more concentrated in the periphery. Myoepithelial cells are present around the duct and sometimes within the bridging structures. The three variants of usual ductal hyperplasia are solid, fenestrated and micropapillary variants. With this, we have completed the session of usual ductal hyperplasia. I hope this session was useful to you. If you like it, I request you all to subscribe, like, share and comment. Thank you.